motion be agreed to. Those of that opinion will say aye. Aye. Contrary, no. The ayes have it.
Electoral Administration Amendment Bill, third reading.
Call Government Order of the Day number 3.
New Zealand Public Health and Disability Amendment Bill, first reading.
Honourable Tony Ryle.
Mr Speaker, I move that the New Zealand Public Health and Disability Amendment Bill be now read for the first time, and at the appropriate time I will move that the New Zealand Public Health and Disability Amendment Bill be considered by the Health Select Committee. Mr Speaker, this bill is not about a major restructuring of our district health boards or the New Zealand Public Health Service. Rather, it is about taking the health board system and making it work better. The way forward to meeting our clinical and service challenges is not having 20 district health boards operating independently, duplicating functions often inefficiently. This bill is about increasing DHB and clinical regional cooperation. This is the first health bill that the new National-led government has introduced to the House since this election 18 months ago. In this time, important improvements have been delivered in a number of public health services, despite the fact that we are experiencing the worst world economic recession since the 1930s. These improvements include a quadrupling of the average annual increase in the number of people getting elective surgery, from under 3,000 more a year to an increase of nearly 13,000 in our first year. We've also seen improved emergency department waiting times and a massive reduction in people waiting more than 6 weeks before commencing cancer radiation treatment. We've also seen the successful capping of the growth in the health sector bureaucracy, with a management administration cap being set for both district health boards and the Ministry of Health. And 1 year on, both the Ministry and the district health boards have responded by stopping that growth, freeing up more resources for patient services, and these are only a few examples of progress. While these gains are positive, it is clear the wider public health system faces many challenges. The election of the new government saw it inheriting a public health system that had many strengths, such as a committed workforce, but many serious challenges. Among the most important of these were workforce shortages, district health boards supplying around $155 million in health services for which they weren't funded, and intensifying pressure on a number of services. An example of this was the pressure on elective waiting lists, which has seen the previous government culling over 30,000 patients from the system, many of whom were promised operations. It is clear that the public health system faces huge future challenges, a potential doubling in demand over the next decade. How do we best meet the health needs of our population, which is both growing and ageing, a population which is expecting increased access to particular health services, such as elective surgery, and rightly aspires to benefit from medical and technical advances? These sit us alongside the need to upgrade and expand our health infrastructure, including our hospitals, IT and equipment, and above all, to grow our health workforce in the face of competition from neighbouring countries with greater wealth. All this in a time of short-term decline in government revenue and forecast moderate medium-term growth caused by the world's recovery from the worst economic crisis. An early priority of the new government was to establish an expert ministerial review group made up of experienced people with health and management expertise from across the health sector, to give their advice on reducing bureaucracy and improving frontline services. This ministerial group consulted widely, met with a wide range of health groups and individuals, deliberated and returned to many groups to test their thinking. Building on the developing consensus on the need for improvement, the MRG developed a forward-looking set of over 170 recommendations. These recommendations covered both very specific recommendations, such as reducing the plethora of committees we inherited, to higher-level major advances such as the establishment of a National Health Board and consolidating planning of IT in the health sector. Most recommendations have been subject to ministerial and official examination and progressed as rapidly as possible. And this bill progresses some of those recommendations more specifically to stop reinventing the wheel 20 times through a better focus on shared services and the power of bulk purchasing. It also focuses on the need for a more regionalised approach to district health board planning of services and a stronger commitment to ongoing improvements in quality. The bill amends the New Zealand Public Health and Disability Act 2000 to support improvements that are required to meet those challenges. The bill provides the framework to improve national and regional cooperation and reduce duplication of back office functions. The bill also supports a greater focus on patient safety across the health sector and responds to calls from health professionals across the nation for an independent clinician-led agency to establish quality improvement across the whole health service. Cooperation between DHBs can improve quality of care, reduce service vulnerability and improve cost effectiveness by reducing the transaction costs of DHBs conducting their own individual processes. When the current DHB model was introduced in 2000, the intention was that DHBs would collaborate and the Minister of Health would be able to use accountability arrangements and policy settings to reinforce the importance of collaboration. And while some steps have been taken by DHBs towards regional collaboration and planning, such as through Health Alliance in Auckland, progress has been limited and it has become increasingly clear that there are barriers, including legislative barriers, preventing DHBs from making genuinely collective decisions consistently and in a timely manner. To address these problems, the bill seeks to improve national and regional service planning and decision making by ensuring that district health boards' planning takes into account national and regional as well as local requirements, and this includes freeing up various reporting requirements to reduce needless administrative costs. The bill will also amend DHB objectives and functions to ensure they work collaboratively to meet national, regional and local service needs, provide dispute resolution measures to support DHBs working collaboratively, and enable elected DHB members to be appointed to other DHB boards. These amendments will ensure that DHBs collaborate to ensure a better balance of district, regional and national priorities in decision-making, which will allow the most efficient use of available resources. The bill also includes proposals to accelerate improvements in quality and safety by establishing a Health and Safety Commission. High levels of quality and safety are the cornerstone of an effective, trusted and efficient health service. To support this, the Government has decided to establish a Health, Quality and Safety Commission as a standalone Crown entity. This will bring a focus on quality and safety not previously achieved. The Commission will be clinician-led. It will empower clinical leadership and foster the necessary clinical engagement to achieve our aims of continuous improvement, quality and safety in health and disability services, including services in private providers like rest homes. In addition, it is estimated avoidable adverse events cost the public health service between $500 and $600 million a year. Realistically, we can't save all of that overnight, but even a 20% reduction in errors arising from a greater focus on quality and safety could save us $100 million a year that could be reinvested in other frontline services. Finally, the bill seeks to minimise administration costs and reduce bureaucracy in the public health service by supporting shared administrative support and procurement services across the public health service. The bill includes a backstop power for ministers to direct greater collaboration and use of shared services by DHBs. We've identified that improving the national approach to shared services could yield significant cost savings, reduced personnel, more efficient systems and a better health service. At the moment, while DHBs can be encouraged to use shared services or processes to obtain administrative support and procurement services, they cannot be compelled to, even when there are clear benefits to that approach. The bill contains a last resort power which enables, after due process and consultation, the Ministers of Health and Finance to direct DHBs as to how to obtain administrative support and procurement services, as well as who those services are required from. This provides the opportunity for a dedicated shared services agency for the public health service to realise the benefits of bulk purchasing and the gains that could come from that. In conclusion, Mr Speaker, this bill is not a major restructuring of our DHBs or the New Zealand Public Health Service. Rather, it is about taking the health board system set up by the previous government and making it work better. It's about recognising that the way forward to meeting our clinical and service challenges is not having 20